Good day, everyone. Welcome to Med Safety Exchange, and thank you for joining us. We know that you are very busy doing great work, and we really do appreciate you being in the audience. My name is Mike Hamilton, and I'm Medical Director at ISMP Canada. The webinar is a production of ISMP Canada and CMERPS, with contributions from all our partners in medication safety and you, the audience. We begin with a land acknowledgement from our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge we are hosted on the lands of the Mississaugas of the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat. We also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. We are grateful to live, work, and play on this land, and we want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. As always, the goal of this webinar is to encourage reporting, sharing, learning from medication incidents, and learning from medication safety topics. We learn best from each other, and we really do appreciate the generosity of our presenters in sharing their expertise and their experience. We hope that you can use the information presented in the webinar in your own organizations and in your own practice, and in turn, share your experience with others. The Med Safety Exchange is presented on the Zoom webinar platform. Ensure your computer is sufficiently loud. The audience members are automatically muted and your video is disabled. And the presentation part of this webinar is being recorded, so will be available on our website in about 2 weeks or so. There are a few ways to make comments or to submit questions. From the Zoom toolbar, typically at the bottom of your screen, use the chat panel to introduce yourself, tell us where you're from. You can also make comments and ask questions via the chat function. All the chat entries will be visible to the audience. If you select the Q&A tool, a window will open up and you'll have the option to submit anonymously if you wish by checking off the lower box. Responses will appear in the Q&A panel and questions will only appear in the panel once they're answered. If we don't get to your question, please email us at medsafetyexchange@ismpcanada.ca and we'll get to you if we possibly can through the offline version. So we do have a really great lineup today covering a wide range of topics. ISMP Canada frequently writes about smart pumps as they do have great potential to increase safety, but the safe and effective implementation of these pumps can be challenging. And we'll hear of a great project and what has been learned from our colleagues out east. We also benefit tremendously from the expertise at CIHI and through the NSIR incident program. And we are very pleased to have them discuss some of the issues in teasing out workload and staffing concerns from incident data. We also know the use of tranexamic acid has increased over the recent years, and with it, we've begun to hear of incidents related to misselection and wrong site injection of the medication. And we're very pleased to hear from Health Canada on this topic. So now I'd like to turn it over to our colleagues at Nova Scotia Health. Adrian, Alana.
Hello, thank you very much for having us. So I'm Adrienne Gallagher and I have my colleague here, Alana McQuaid, and we are pharmacists on the technology-enabled practice team within Nova Scotia Health. We have a few other members of our team joining as well, I believe. And we're here to talk about smart pumps, our post-implementation findings and lessons learned. Next slide, please. So just a really quick outline of what we wish to accomplish today. We want to very briefly discuss the project scope of implementing the smart pumps, but our main focus will be on our Infusion and Practices Assessment Evaluation and the report it generated, with special focus on the opportunities for improvement identified, as well as the successes identified in that report, and then potential next steps. So if you're not familiar with Nova Scotia, we actually have 2 health authorities. One is one hospital, our Women's and Children's Hospital, the IWK, and the rest of the province all falls under Nova Scotia Health, which is further delineated into 4 zones. And prior to our smart pump implementation project, only a portion of one zone had previous experience with smart pumps, so it was a pretty novel concept at that time. Next slide. So the reasoning for implementing smart pumps was twofold, two main goals. One was to meet international and national standards, including those that are set out by ISMP, to implement smart pumps with dose error reduction system, or DERS, and also to improve patient safety. Between 2019 and 2021, our implementation team trained approximately 5,000 clinicians, and we implemented 6,300 pumps in 44 healthcare facilities and 284 clinical areas across the province. So just a little bit of a timeline. We started our implementation in March 2020, and we completed our implementation a little over a year later in April 2021. And the data we're going to discuss today was collected between September and December 2021. So the reasoning behind doing this evaluation, prior to our implementation, the vendor actually went around and did their own evaluation across, and they wanted to look and understand current practices as well as identify areas for standardization. So our goal in our post-implementation evaluation was to indicate the success of these interventions that we made during our implementation, evaluate compliance with best infusion practices as well as policy, and to identify any pain points or areas for improvement in the smart pump use that might be addressed so we can increase compliance and decrease workarounds. So 4 data collection tools were developed. There was a non-clinical audit, which focused on the tools and equipment available to staff. There was a clinical interview that allowed the staff to discuss their infusion practices generally, as well as their experiences with the smart pumps. A clinical observation portion where our team was able to observe clinicians infusing medication, and then a pharmacy survey that explored our pharmacy staff experiences with the smart pumps. So consistent data collection team was trained and deployed to all 44 healthcare facilities in Nova Scotia Health where our smart pumps are being used. And the results were 277 non-clinical audits, 475 clinical interviews, 897 clinical observations, and we received 39 responses to the online pharmacy survey. So the evaluation revealed a variety of successes of the smart pump implementation and positive changes in practice that we have seen since the smart pumps have been implemented. There were also a variety of areas identified for improvement. The key findings of the pre-implementation evaluation that we discussed that the vendor had completed were used as a comparator for this evaluation, and recommendations that they had originally identified were reviewed within our report. Obviously, we don't have the time today to review the full amount of data we collected, but we're going to focus on a few highlights now. We're going to start with areas for improvement, and I'm going to discuss each of these on their own slides starting now. So of note, our pumps require a head height differential to deliver secondary drugs. So that's demonstrated in this photograph here, with a secondary infusion or the B bag being hung higher than the primary infusion or the A bag. So full dose delivery is achieved when the secondary bag, the drip chamber, and the secondary line is empty, and then the primary line is flushed subsequent to that infusion. So observation and interview data identified that the amount of drug delivered from the secondary line did vary significantly. Only 6% of observed secondary infusions achieved this full dose delivery, with 36% of infusions have the bag, drip chamber, and secondary line completely empty, which is reasonable. There are obviously potential clinical negative clinical outcomes of not delivering the full dose, and that includes antibiotic resistance of using antibiotics, obviously, potentially increased therapy days, increased duration of patient stay, and potentially poor patient outcomes. Obviously, all these negative clinical outcomes have significant financial costs, but there's also financial costs associated with potentially getting rid of or throwing out a bag or a line that still has medication in it, and a financial analysis was actually completed on our most used drugs, considering the scenarios in which the bag was not completely delivered. Next slide, please. Thank you. Our flushing technique and frequency was also identified to be less than ideal. 75% of respondents flush using a straight flush technique, but Best Infusion Practices actually recommends using a pulsatile flush technique. And ideally, the line would be flushed before and after medications, and then routinely during shifts to keep the device patent. We had about 60% of respondents saying that's their current practice, but obviously we'd like to see that higher, considering that is best practice. And there was a large range in the volume of flush that was used. 41% of respondents said they used 10 mils, but in most clinical scenarios, 3 to 5 mils would be sufficient. Similarly, infusion line changes show wide variability. 27% of nurses were changing out lines at 24 hours, 6% at 48 hours, and 50% at 72 hours. Infusion lines should be changed out according to best practice, a minimum of every 4 days and up to 7 days unless otherwise indicated. And there seemed to be an unawareness of standards among a lot of our clinicians. Additionally, our observational data showed that 71% of primary lines were unlabeled, likely meaning that the line would be changed more frequently as the clinician would be unaware of when it was hung originally. And there are obviously risks with changing the line more frequently than required, one being a potential introduction of infection every time it is the line is open, and 2 is obviously associated financial costs, especially if you're changing out a line potentially 7 times more than is necessary. And an analysis was done as well in these scenarios as well. Up to 53% of our pumps were not plugged in when our team went around, despite most areas having enough electrical outlets to do so. And this photograph was actually captured by our team during their evaluation. It's a clinical area where pumps were stacked, but they weren't unfortunately plugged in, and they're actually piled in front of a resuscitation cart, which is not ideal. If our pumps are not plugged in, data is unable to flow to and from the pumps, with 4 major consequences, including pump location not being available, drug library updates not being received, draining on the batteries, which may require the pumps to then be sent to biomed, and CQI data is no longer sent to our server. There were also just a few general infusion issues that were noted throughout the evaluation. The first being intermittent primary infusions were noted to have the correct compatible sterile covering device. Unfortunately, only 44% of recorded observations. However, looping, which there's a photograph here, where the open end of the line is connected to the lowest port, was prevalent in 41% of total observations. And in 10% of total observed infusions, the end of the line was left uncovered or unprotected. So obviously we'd like to see the sterile end of line covering used more frequently. Of those respondents who managed multiple infusions, 26% used a multi-port connector, while the practice of 75% was to stack the lines at the lowest port. And a multi-port connector was only seen in 3% of all observations. And best practice would recommend using a multi-port connector when you're using more than one infusion. And gravity infusions were administered rarely or never by 77% of respondents. But in the era of smart pumps and the availability of smart pumps, there's really very little clinical scenarios that require gravity. So we'd actually like to see that number even higher for people having rarely ever seen the use of gravity infusions these days. And lastly, we just want to touch on clinical resource availability. It was a recommendation of our project that all med rooms have a kiosk-style mounted tablet or laptop to allow quick, easy access to the infusion therapy resources. And unfortunately, when our team went around to do the evaluation, only 49% of med rooms had that available. And this just means that a lot of staff are spending unnecessary time trying to seek out a workstation to look up administration resources, and might be causing issues in their time management, as well as potentially errors as they're trying to find those resources.
Great, so I'm going to take over now. Good afternoon, everyone. So while we did have a number of areas for improvement, we wanted to leave you on a high note and talk about some of the successes from both the implementation and the post-implementation survey. So I will highlight a few of those on the next few slides. So the first being staff attitudes. So with very few exceptions, staff was consistently positive about the introduction of these smart pumps. Not only were they willing to, train in a difficult time. We were doing this in the middle of a pandemic, but they really always came back with the desire to improve patient safety and realizing just how important these smart pumps were in improving that safety. We also had a lot of great feedback with our Infusion intranet site, and that's basically a website that's available on each desktop within the organization, and it's meant to be a repository for all things infusion therapy, so things related to the smart pumps as well as some resources. And on the next slide here, you should be able to see, this is our main website here. So again, a repository with some great information. We have some training videos related to the pump. We have some one-pagers for clinicians related to pump practices. We have some lookup tools for our libraries and some forms available if someone has something that they need to request changed or added to one of our drug libraries. Our drug X use is also within recommended levels. So for those not familiar with drug X, that's basically a generic entry that can be found in every library in the pump. And it's meant to be something that's there for situations where other drugs, the drug is not available for some reason in our library. So it has to be manually programmed in terms of the volume, the rate, and all those other parameters, similar to a non-smart pump. So we really don't want to be using that entry much if possible. And ISMP actually recommends compliance to 95% or more within using the DERS or the drug library itself. So we're happy to report here. Over on the right, you can see our drug X use by profile. And for most of our libraries, we are meeting or exceeding that standard of 95% or better. Quality improvement is something else that we really wanted to focus on. We didn't want to just implement the pumps and then never have a look at the data that we can grab from these pumps. So as Adrian alluded to, all of the infusion information is sent to a server, and we have access to that server in order to look at information with the goal of improving our infusion practices and our drug libraries. So we did form a continuous quality improvement group, which is led by Adrian and myself. And the goal of that group is to meet quarterly, looking at our reports that come from that server in order to make recommended changes and to provide education where needed. So that can be things around improving a drug library if we're seeing high drug X use, or tweaking a setting in the pump if we're seeing things like high alarm rates, for example, air in line. There's also been a project done at one of our zones where they've stood up a practice committee to embark on a quality improvement project to reduce the use of secondary IB lines with a goal of reducing the use by 25%. And if that's successful, this will represent a cost saving to the unit, but it'll also achieve fewer unnecessary line changes to protect the closed system and prevent contamination. Pump access is something that has improved as well with the implementation. So prior to our implementation, there was a note that there were just not enough pumps in circulation. So we did implement more pumps or replace more pumps than we had originally had. So there is better access just because of that. But we do also have access to a location dashboard, which tells us where pumps are. And with our implementation, kind of what we have followed is that the pump actually follows the patient. So if a patient is being transferred from a smaller site into a more regional site, that pump will follow. And so as you can imagine, pumps begin to kind of gradually gather at those regional sites. So we have these pump garages. So this is an example in this photo here where you can see, and it's just essentially a room full of pumps, and it's a site where our smart pump coordinators can come in and send pumps off to other sites if need be, or it's where a nurse can come to either drop off or pick up a pump if there's more or less required on their unit. So this has been something that has been very successful with our implementation. We didn't want to leave out our pharmacy staff. Adrian and I are both pharmacists, and we knew that coming in, anything that's related to medication management or medication questions tends to make their way back to pharmacy staff. So we did involve them in our post-implementation survey and the implementation itself. So when we were implementing, we provided education to pharmacy staff. We did 1-hour presentations to give them all the information we felt that they would need. And then in the post-implementation survey, we wanted to go back and see how they were doing in terms of, do they have the information that they require? And as you can see on the chart here, people do receive questions regularly related to the pumps. So we wanted to ensure that they had the resources they needed. And most of the staff do feel that they are fully better equipped now to be able to provide answers to those questions, or at least lead the clinicians to our website where they can find the information they need. Standardization was another big one. We had to standardize as much as possible prior to our implementation, because even though we are the one main health authority, we were still very much working zonally and even within sites in some areas. So an example being our order sets, where there were several different things out there for the same kind of issue. So we really took this as an opportunity to standardize as much of that as we could. We also had to standardize things like standard concentrations for drugs, drug and dosing units, and a reason for that being that, for example, the same critical care library that we use in the southern part of our province is the same library that's to be accessed in the northern part. So we really wanted to have as much of a standardized process as possible. And finally, for next steps, our main goal is, of course, to get the information out there to the folks using the pumps. So we really want to communicate the results of our report as widely as possible and support education as much as we can. We've also stood up a parenteral practices committee, and this will be a new committee that has provincial representation with the goal of identifying and addressing practice concerns, policy implementation, procedure implementation, and reporting back to zone medication management committees in order to support best practice initiatives. So I think that's it from us. And I guess at the end of the presentation, we're happy to take questions at the end of everyone's talk, or feel free to send us anything you'd like to ask in the chat.
Thanks so much to you both. What an enormous exercise you've undertaken. But you really, I think, focus and highlight how important it is to evaluate what you've done. There's always opportunities to improvement, and it's quite evident that you're taking advantage of them. So thank you for that great presentation and great learning. Now I'd like to turn it over to our good friends at CIHI to tell us of their recent work on workload and staffing.
Thank you very much. My name is Grant Fuller. I'm a senior analyst on the NSIR team at the Canadian Institute for Health Information, and I'm also trained as a pharmacist. Today I'll be sharing an analysis we did looking at workload and staffing challenges and kind of what information NSIR holds on that topic. So some quick background on NSIR. NSIR stands for the National System for Incident Reporting. It is a voluntary and anonymous reporting system for both medication incidents as well as radiation treatment incidents. And really the purpose of the system is to facilitate sharing and learning from these incidents when they do happen, ultimately with the goal of helping to prevent similar incidents from occurring again in the future. Next slide, please. NSIR works very closely with our data submitters as well as partner organizations to do the work that we do. Some of those partners are listed on the slide here, and I see some are on the call today, so that's excellent. Next slide. So really what we want to answer was what information can NSIR provide on this recurrent issue that we all keep hearing about on excessive workload, burnout, and the staffing challenges being faced within the health workforce. Next slide. When thinking about where to look within the NSIR data to kind of get at this question, one data element that came to mind certainly was contributing factors. The definition we use for contributing factors is listed on the screen. So a contributing factor is a circumstance, action, or influence which is thought to have played a part in an incident occurring, essentially, or which increase the risk of an incident occurring. Within NSIR, there are 73 contributing factors data submitters can choose from when submitting an incident across 10 high-level groups. And within the NSIR application, these are kind of posed to users as a series of checkboxes that you can choose from. Within NSIR, there are a collection of contributing factors related to workload and staffing challenges. So things like stress or fatigue and exhaustion being experienced by the healthcare provider. There's also contributing factors on hours of work and workload, as well as contributing factors on insufficient staff or inexperienced staff as well. Next slide. In the interest of time, I won't go into the whole methodology of how we looked at those coded contributing factors, but instead I'll summarize the results. What happened when we looked at those coded contributing factor checkboxes related to workload and staffing? The results were quite mixed, actually. Some of those contributing factors were being used more over time, some were being used a bit less, and some were being used at kind of similar levels. And then those results also varied based on if we looked at the individual contributing factor checkboxes versus the higher level groupings, as well as if we looked at the data nationally versus provincially. Some thoughts we had when we saw these initial results, we did wonder whether data submitters were always finding the most appropriate option to select, given that there's so many contributing factors to choose from. As well, we considered how the user interface when selecting those contributing factors may have affected the results. As well, when seeing these results initially, they really did not, at least anecdotally, reflect our experience actually reading through a lot of these incidents, where we have come across a notable number of reports where in the free text incident descriptions, they're referencing challenges related to workload or staffing levels, or just generally feeling rushed, seemingly as contributors to those incidents. So kind of mixed messages with the results we saw initially. Next slide, please. So that led us to ask kind of an extension to that question. Are incident submitters referencing these concepts of increased workload, burnout, or staffing challenges at an increased rate, specifically in the free text that they submit to answer, instead of in those contributing factor checkboxes? Next slide. Thank you. To do this, we conducted a keyword search. We targeted all of the main answer free text fields, so the description of incidents, any strategies or recommendations which have been posed, as well as any actions or circumstances that prevented patient harm. We chose a set of keywords which would limit the incidents we pulled to a manageable number to filter through manually, as I'll describe a bit further on. And then we specifically wanted this keyword search to capture incidents with the theme of workload or staffing challenges, specifically as contributing factors to those incidents occurring. That is to say, we didn't just want these keywords to appear incidentally in those incident reports, but rather than be referenced seemingly in a way that kind of suggests those factors were related to those incidents occurring. Next slide. Here is kind of an overview of part of the keyword search. On the left, you'll see some keywords that we tried. So they are terms like workload or burnout. They are terms such as feeling rushed or feeling stressed on the part of healthcare providers. There are terms such as staffing or short-staffed. There's as well terms like exhaustion or fatigue. And then there are terms such as resources, as in we're lacking in resources, or capacity, so beds being at or over capacity. Some of these keywords were more successful than others, but this is kind of the general theme of the words we decide to search by. Next slide. From that initial search, we identified 500 potentially relevant medication incidents to look at further. And then the next step was to manually screen through those incidents to ensure they fit that target theme. So one, to ensure that our keyword search did not capture any unintended terms. And then two, for when the keyword search did capture those intended terms, that they were being used in the intended sense or in the intended meaning. Next slide. This is an example of an incident that we excluded from the initial 500. And then I'll read it to you and tell you why. So here they state this patient went into query acute heart failure this morning. The internal medicine team was consulted. One of their orders was for a nitroglycerin patch to ease the workload on the patient's heart and to keep a lower blood pressure. So here they've used one of the keywords we were interested in, that being workload, but they've used it in kind of a context or a meaning separate from workload from a staffing perspective. So we excluded this incident. Next slide, please. After manually filtering through those 500 incidents, we were left with 300 after excluding incidents. And then from there, the idea was to see, are data submitters referencing these workload and staffing challenges more or less over time? So what we did was we graphed those incidents over time, and you can see that here. On the x-axis, we have the year in which those incidents were detected. And then on the y-axis of the 300 incidents we were left with, We graph them as a rate for every 100 incidents being reported to NSIR. And that's just to account for any changes in the number of incidents being reported over time. And what we saw was that, yes, incident submitters are seemingly referencing workload and staffing challenges in the free text of incidents significantly more frequently than they used to. And that was really in direct contrast to what we saw with those contributing factor checkboxes, where the results were quite inconclusive. Next slide. Looking at what individual terms were driving this result, it's largely a function of the term workload. So data submitters are referencing workload challenges or excessive workload or increased workload, seemingly as contributing to incidents more than they used to within the free text of what they submit to NSIR. As well, terms like staffing and capacity, so beds being over capacity, are also mentioned more than they used to be. Next slide. The focus so far has really been on graphs and charts, but having read through many of these incidents, we certainly encountered some very compelling narratives relating to kind of the experience frontline healthcare providers are having in terms of workload and staffing challenges and how those may contribute to incidents. So I wanted to highlight two of those for you. Here they state the writer was giving medications. They were going through the medication administration record and couldn't find half the pills on that document. The writer then went to the night cupboard to get the missing medications. The writer realized right after giving the medications it was to the wrong patient. Patient was given apixaban, lorazepam, and metoprolol. Writer notified the physician the patient's vitals are good, and the writer will monitor the patient throughout the night and do blood work in the morning. Error is a result of workload. 16 patients is too many for one nurse to be giving meds to while answering call lights. Ongoing issue with this ward, nurse did not check the patient's ID before giving medication. Next slide. And the final example, they state, writer was doing medication administration. Writer confirmed the patient's first name, but not their last name. This resulted in the medication being administered to the wrong patient. This was the writer's first day. Writer was supposed to be oriented today, but ended up taking on a patient load because we were short-staffed. Next slide. A few limitations to this approach to discuss. We did not include every potentially relevant term to this question of workload and staffing challenges, just to keep the scope of the analysis manageable. As well, the final data set we ended up with of about 300 records is relatively small, so it's hard to detect changes in any individual term when it's only used a few times a year. Finally, the step where we filtered through the incidents was somewhat subjective, so just to note that. Next slide. So to conclude, what we found is that free text mentions of workload and staffing challenges as contributors to incidents in NSIR are up over time and up fairly significantly. And that is in contrast to what we saw when we looked at the actual contributing factor checkboxes related to workload and staffing, where the results were quite mixed. And finally, we again think this highlights the importance and the value of those free text fields when you are submitting data to an incident reporting system. Within NSIR specifically, these are optional fields. They do not need to be submitted, but we certainly think that there's a lot of valuable learning that can be done by reading through and by learning from these incidents. So certainly something we would encourage reporting if you're able to. And that is what I have for you. Thank you very much.
Thank you, Grant, and your colleagues at NSIR. I mean, staffing and workload issues have really come to the fore during the pandemic, and it's really interesting to understand from the reporter's perspective how they express that, whether it's through, you know, the predefined contributing factors that you select in the drop-down boxes, or as you've kind of discovered through this work, more through the stories they want to tell. So thank you. I really look forward to learning more about this.
Thank you.
We now welcome our friends at Health Canada to present a regulatory perspective on an issue of great recent concern, and that's errors involving injectable tranexamic acid.
Thank you, Mike. Good day, everybody. Thanks for having me. My name is Parag Butch. I'm a patient safety specialist in the Marketed Health Product Directorate in Health Canada. Next slide, please. So this is my little outline. I would like to have a little bit of discussion on the topic of wrong drug medication errors with tranexamic acid injection, errors with tranexamic acid injection or substitution errors, highlighting Health Canada's role in collaboration with ISMP Canada in identifying the safety concern, recent product safety updates made to Canadian reference products product monograph, and to raise awareness among all healthcare professionals regarding this global medication error issue. And then I'll briefly explain Health Canada's regulatory authority in approving drug names, packages, and labels, including labeling, which is product monograph. Health Canada authorized indications for tranexamic acid and its potential off-label uses that were also noted during our analysis. I'll briefly review the information on the topic, on this topic from the 2 safety alerts published in recent years. And then I'll provide brief synopsis of Health Canada's work and actions taken on the issue under our federal jurisdiction. I'll then provide some images, mock-up product or mock products in the Canadian markets. Next slide, please. So under the Authorities of Food and Drugs Act and its regulations and subsequent analysis done by Health Canada approved drug names, packages, labels, and labeling. Product information such as product monograph, as we call it, labeling, which are submitted by the pharmaceutical industry. Our primary focus in our section or the Marketed Product Directorate with the few teams of pharmacists is to prevent and manage harmful medication incidents or errors that resulted from a drug name, package, label, or labeling. In Health Canada may take regulatory action requesting the market authorization holder to revise product names, labeling, or packaging if a safety issue is identified. As we all know, the prevention and management of medication incidents require a collaborative approach between Health Canada, industry, health professionals, and facilities, patient safety organizations, patients, and consumers. Next slide, please. We know that tranexamic acid is antifibrinolytic agent that prevents the breakdown of fibrin, thus promote clotting. According to the Canadian product monograph, the tranexamic acid tablet and or injection is indicated for hereditary angioneurotic edema, to prevent and reduce bleeding from cervical cone surgery, tooth extraction, nosebleeds, and bleeding inside the eye, and reduce bleeding with heavy menstrual period. Tranexamic acid solution for injection is intended only for intravenous use. Next slide, please. According to available literature and clinical use information, a tranexamic acid injection is also used off-label in a variety of hemorrhagic conditions to control bleeding, including postpartum hemorrhage, acute trauma, hip and knee surgeries, and gastrointestinal bleeding. Although tranexamic acid injection is not authorized for use in certain surgeries, it is often used intravenously or topically during these procedures to decrease blood loss. Next slide, please. For interest, this chart provided here illustrates available tranexamic acid products in Canada. There are around 23 drug identification numbers issued for tranexamic acid products, including tablets and injectable formats. However, only 6 injectable products are available in either ampule or vial formats with different volumes. Next slide, please. In September 2020, in the US, the National Alert Network issued an alert reporting dangerous wrong route errors with tranexamic acid. I'll go a little bit of deep in alert to brief you guys. That the alert describes 3 cases of accidental spinal injection of tranexamic acid instead of local anesthetic intended for spinal anesthesia. We found that in the alert, the container mix-ups were involved in each case. In one case, a patient scheduled for knee surgery received tranexamic acid injection instead of bupivacaine. Patient had seizures, however, recovered. In second case, a patient was undergoing hip replacement surgery, received a tranexamic acid injection instead of local anesthetic for spinal anesthesia. Patient survived but experienced seizures and extreme pain. In third case, a patient scheduled for bilateral knee replacement also inadvertently received tranexamic acid injection instead of bupivacaine for spinal anesthesia. Patient also experienced seizures and required placing her into an induced coma for several days. The non-alert also notes that in the US, bupivacaine, ropivacaine, and tranexamic acid injectable products are packaged in vials that may have the same blue color cap. While vial label colors and vial sizes may be different or dissimilar, not looking alike, when the vials are stored upright near each other, only the blue cap may be visible, making it more difficult to differentiate one drug from the other. Next slide, please. In March 2022, the WHO alerted healthcare professionals about the risk of medication errors with tranexamic acid injection, resulting in an inadvertent and intrathecal injection. The alert also describes reports of tranexamic acid injection being mistaken for obstetric spinal anesthesia use for cesarean deliveries, resulting in an inadvertent intrathecal administration. Tranexamic acid injection administered intrathecally would be potent neurotoxin, as we know, and neurological sequelae have been seen with refractory seizures, and approximately 50% mortality is recorded. A 2019 review identified 21 case reports of inadvertent intrathecal injection of tranexamic acid injection. Since 1988, of which 20 were life-threatening and 10 were fatal mistakes. 16 were reported between 2009 and 2018. The alert also notes that the injection is frequently stored in close proximity with other medications, including injectable local anesthetics indicated for spinal anesthesia, for example, cesarean section. Next slide, please. So in Health Canada conducted medication error analysis pertaining to inadvertent administration of tranexamic acid injection. The cases what we looked at was Canada Vigilance Database, in-house Health Canada's database, and we found no reports of concern or error reports of such nature. Subsequently, Health Canada asked ISMP Canada to check their databases for any cases involving mix-ups between tranexamic acid injection and anesthetics. ISMP Canada found one report in their consumer reporting database from a patient who was inadvertently given tranexamic acid injection into the spine as a result of drug substitution error. The alert describes during an orthopedic surgical procedure, tranexamic acid injection was inadvertently administered into cerebrospinal fluid instead of intrathecal local anesthetic, that was bupivacaine, that was intended. The patient reported adverse effects and experienced seizures. At the time, neither anesthesiology team or the surgical team recognized the error at the moment. The error was identified only when same error occurred during a subsequent procedure later that day. Unfortunately, the patient had been bedbound and living with extreme pain. The error has permanently and significantly affected quality of life of patient and their own family. The incident was published in ISMP Canada's alert on May 26, 2022, describing substitution error with tranexamic acid during spinal anesthesia. This alert also provides several good practices and recommendations to decrease the risk of this type of error and may improve safe use of tranexamic acid injection. The recommendations are also included for storage and supply, product and equipment, and operating room procedures. It also encourages medication suppliers to provide tranexamic acid injections in diluted form, either in ready-to-use mini bag for IV infusion, since it is commercially available in other countries. Health Canada also conducted mock-up labeling and packaging analysis for the marketed tranexamic acid injection products in Canada, and found that most of the marketed vial formats have white or clear caps versus blue colored caps for bupivacaine products as identified in the US. However, we found similarities in cap colors for a few anesthetic products and tranexamic acid vials. The tranexamic acid injection labels clearly identified, although for IV use only or for intravenous use only. Next slide, please. So in Health Canada's review of labeling, we noted some opportunity to include information on this error in the product monograph. So in November 2021, the contraindications, warning and precautions, and dosage and administration section, including patient medication information section of the Canadian product monograph for the reference product cyclopepron were updated with the risk of errors due to incorrect route of administration. The contraindications is now clearly states that intrathecal and epidural administration of tranexamic acid is contraindicated. Dosage and administration section clearly indicated for injection or infusion use only. And it also highlights erroneous administration of cyclopepron or tranexamic acid solution for injection via intrathecal or epidural route has resulted in serious harm, including death. Accordingly, warning and precaution section was also updated. The same product safety update has been published in January 22 in Health Canada's monthly InfoWatch publication for this product monograph update. Being said that Health Canada encourages healthcare providers to report medication error to CMERPS, which is Canadian Medication Error Reporting and Prevention System. Through collaboration with Health Canada, these reports can contribute to labeling and packaging improvements for health products and to change the product monograph and to bring some improvements on product labeling. Next slide, please. Here are some images or mock-ups for tranexamic acid vials available in Canada, followed by bupivacaine mock-ups or images on the next slide, please. So this is a bupivacaine. You can clearly see that there are some caps similar to tranexamic acid vials, which are white in Canada. Next slide, please. Thank you for your time, and you can reach us in the email provided on this slide or reach out for any questions you have through ISMP as well. Thank you for your attention.
Thank you so much, Parag. And these concerns over injectable tranexamic acid really demonstrate how you need multiple interventions across many levels in the system, from regulatory to bedside to everywhere in between, to things like cap color, how you store them in your own facility. So very complicated. It's a struggle, it seems, around the world. So I'm glad we're all working on this.
Thank you.
So the chat box and the Q&A have been very active today, and we really thank you for submitting your comments, and thanks to all the panelists for sharing their experience and expertise during their presentation. We have time for a couple questions. I think I will focus on Grant, if you could, from NSIR. When doing your analysis about workload, did you detect any association between workload staffing and levels of harm?
Not that I recall. Again, the data set was very small after we filtered out incidents which we deemed not relevant to the topic, and across the years that dilutes it even more. So nothing that I could point to on that front, though it's an interesting question.
And as you did the analysis in the context of the general media and general reflections of healthcare during the pandemic, there was a lot of talk about staff workload and staff burnout. Do you think that influenced reporting at all, just the general awareness of these issues?
I think it would, at least to some extent. And I think there was a question in the chat to that effect, like how can you separate an increased awareness of these workload challenges and wanting to report that in incidents versus true workload, or however you want to phrase that. I think you're absolutely right. I think it did influence the results. To what extent, I can't say, but I would think that it's a combination of both factors, an increase in workload and an increase in awareness of these challenges as well.
Thanks, Rand.
Thank you.
Perig, if you're able to comment from an audience member, one of the recommendations from ISMP Canada's bulletin is to encourage medication suppliers to provide the tranexamic acid in a diluted form in a ready-to-use mini bag infusion as it's available in other countries. What influence does Health Canada have over manufacturers, or is there any influence that you have over how the medication would be supplied?
Great question, Mike. What I would say in terms of regulatory work, what we do here is that we work with the submission information. So if a manufacturer is submitting particular packaging format, we need to work with that format. But if it has created some safety issues, then we will, do some analysis work and look at what is available internationally. And then we can definitely ask manufacturer whether they have some information on any case report or as such. Sometimes manufacturers picks up by themselves and they start working on that area. But as we know, manufacturing is complex, and this may require a big commercial manufacturing facility for manufacturing such kind of product. Being said that, there are some commercial products available, commercially mixed products. We certainly encourage manufacturers to do that and to explore. The only thing is, it depends on the business willingness versus, I would say, the number of products what they're selling. So for example, if it's being sold in US for a lot of quantity, then the manufacturer might make a decision to make this product available. There are good label and packages practices guide we like to follow, but as I said, it's a complex one. Manufacturers try to pick up on those, and based on the business proposition, they might bring it up for our review.
Great, thank you. Adrian and Alana, you've been so busy answering questions in the chat box. I think we'll give you a break on this time, but certainly thank you. You've been very engaged. I do want to thank everybody, all the presenters, for the terrific learning that they shared today and their efforts towards improving patient care. And we really want to thank you, the audience, for learning along with us. Again, please let us know what you think about this by contacting us and certainly completing the feedback poll that you see in front of you. We learn from stories, we learn from conversations about errors, and we learn from multiple perspectives, the patient, the practitioner, caregivers. We learn from systems. Please share the experience and the stories that you have in order to make the care safer. Please be part of the Med Safety Exchange. Please reach out to us. We're always interested in hearing from you, and we will help you along every step of the way. Again, the link to the recording of this webinar will be available on the MedSafety Exchange website in the next few weeks, along with links to websites and materials, and the PDF of these slides is available upon request to the email address listed on the slide. The next webinar will be in May 2023, so please stay connected with us so we can let you know when the date is finalized. Thank you for tuning in, and we all hope you enjoy the rest of the day.